Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. Ozempic, Wegovy, and Mounjaro. These drugs have reshaped modern metabolic medicine. Millions of people are losing weight, controlling their blood sugar, and reducing cardiovascular risk with these drugs. But there's a side effect that receives far less attention. GLP-1 receptor agonists are associated with an increased risk of gallstones and gallbladder disease. And when you examine the physiology, the connection is not accidental. It is pharmacologic. In this video, we'll break down the key mechanisms linking GLP-1 receptor agonists to gallstone formation, from impaired gallbladder contraction to changes in bile composition, and why these pathways converge on one central problem: biliary stasis. First, a quick orientation. GLP-1, or glucagon-like peptide 1, is an incretin hormone released from intestinal L cells after meals. This hormone activates the glucagon-like peptide 1 receptor, a G protein-coupled receptor. GLP-1 receptors are widely expressed in the pancreas, brain, gut, and cardiovascular system. Importantly, they also influence pathways that regulate gallbladder motility. GLP-1 receptor activation enhances glucose-dependent insulin secretion, suppresses glucagon, slows gastric emptying, and reduces appetite. GLP-1 receptor agonists, like semaglutide and liraglutide, mimic this hormone. Now, why does the gallbladder matter? It stores and concentrates bile. After a meal, particularly one containing fat, it contracts in a coordinated fashion to deliver bile into the duodenum. If contraction is weak, delayed, or incomplete, bile remains in the gallbladder. It becomes concentrated. Cholesterol can exceed its solubility threshold, and crystals form. That is the starting point of cholesterol gallstones. So let's walk through the four mechanisms. The first mechanism is suppression of CCK, or cholecystokinin. CCK is the primary hormonal trigger for gallbladder contraction. When fat and protein enter the small intestine, I cells release CCK. CCK then stimulates forceful coordinated gallbladder emptying. Here's the problem. GLP-1 receptor agonists slow gastric emptying. This is one of their therapeutic benefits. But slower gastric emptying means less nutrient delivery to the duodenum, especially after meals. Less stimulation of I cells means reduced CCK release. Reduced CCK means weaker gallbladder contraction. And a weaker contraction means incomplete emptying. Bile remains. Water is reabsorbed, and cholesterol concentration rises. Those cholesterol crystals are the seeds of gallstone formation. This mechanism, impaired gallbladder emptying due to reduced CCK signaling, is the most consistently supported and clinically relevant pathway. Let's talk about a second lesser-known pathway, the TGRS signaling disruption. And fair warning, this one is still being actively studied, so think of it as emerging science rather than settled fact. Inside your gut, there's a receptor called TGR5. Think of it like a sensor that bile acids can switch on. When bile acids flow through your intestine and activate TGR5, two things happen. First, it tells the gallbladder to relax and hold on to bile until the right moment to release it. It does this through a chemical messenger inside the cell called cyclic AMP. Think of cyclic AMP as the stay calm signal for the gallbladder muscle. Second, and this is the interesting part, TGR5 activation also triggers the gut to release GLP-1. Yes, the same GLP-1 that these drugs are mimicking. So in healthy physiology, your own bile acids help regulate GLP-1 levels. Bile and GLP-1 are part of the same feedback system. Now here's what researchers think happens when you take a GLP-1 receptor agonist. The drug is constantly activating GLP-1 receptors throughout the body, including in the gut, at a level far beyond what your own biology would normally produce. When your gut then tries to send its own natural, mealtime GLP-1 signal through the TGR5 pathway, it's essentially shouting into a room where the music is already too loud. So, the signal gets lost. The gallbladder loses that precise, meal-timed cue it normally relies on. And the coordinated relax then contract rhythm gets disrupted. Contractions become poorly timed and less effective at clearing bile. The third mechanism involves biochemistry changes via the disruption of FXR-FGF19. When bile acids reach the ileum, they activate a nuclear receptor called FXR, the farnesoid X receptor. Activated FXR triggers the gut to produce FGF19, or fibroblast growth factor 19. FGF19 travels through the portal circulation to the liver, where it acts as a critical feedback signal to suppress bile acid synthesis. How? By down-regulating CYP7A1, or cholesterol 7-alpha hydroxylase, the rate-limiting enzyme in the main bile acid synthesis pathway. Additionally, FGF19 regulates the bile salt export pump, or BSEP, which is the main transporter for bile acids out of hepatocytes into bile. Disrupt BSEP, and you alter both the volume and composition of bile secreted. Now, each of these individual components is well-characterized biology. The FXR, FGF19, CYP7A1 axis is textbook hepatology. And the role of BSEP is firmly established. What remains to be confirmed in clinical research is exactly how GLP-1 receptor agonist use reduces FGF19 levels in patients, and whether this reduction is sufficient to meaningfully alter bile composition and drive gallstone formation. With that caveat in mind, here's what the current evidence suggests. GLP-1 receptor agonists appear to reduce FGF19 production, likely because slowing gastric emptying reduces bile acid delivery to the ileum, weakening the FXR signal. With less FGF19, the normal brake on CYP7A1 is released, and the liver overproduces bile acids. This disrupts the carefully regulated enterohepatic circulation. Simultaneously, reduced BSEP activity means fewer bile acids are actually secreted into bile. Since bile acids are what keep cholesterol dissolved through micelle formation, less bile acid in bile means cholesterol can no longer stay dissolved. It starts to crystallize out. And those crystals, forming in already stagnant bile, are exactly how gallstones form. The fourth mechanism brings in the central nervous system. GLP-1 receptors are expressed in the brainstem, specifically in the nucleus tractus solitarius and the area postrema, components of the dorsal vagal complex. These regions regulate the autonomic output to the gastrointestinal tract. The vagus nerve plays a major role in coordinating gallbladder contraction after meals. Activation of central GLP-1 receptors alters vagal tone. Experimental data suggest this modulation can reduce gallbladder motility. So, even when hormonal signals like CCK are telling the gallbladder to contract, the neural coordination of contraction may be dampened. The gallbladder tries to empty, but can't do it effectively. Once again, impaired emptying. So let's bring it all together. CCK suppression leads to reduced contractility. TGR5 dysregulation disrupts the cyclic AMP-mediated relaxation contraction cycle. FXR-FGF19 disruption alters bile acid synthesis and composition. And central GLP-1 receptor activation causes asynchronous vagal-driven contractions. Across these mechanisms, the endpoint is the same. Prolonged bile retention, cholesterol supersaturation, crystal nucleation, and stone formation. That is the textbook environment for cholesterol gallstone formation. And clinical data backs this up. Observational studies and pharmacovigilance data have shown increased rates of cholelithiasis and acute cholecystitis in patients treated with GLP-1 receptor agonists. especially at higher doses and longer durations of use. So, what does this mean in practice? Understanding the pharmacology doesn't mean avoiding these medications. GLP-1 receptor agonists are genuinely transformative drugs. The cardiovascular and metabolic benefits are well established and substantial. But understanding the mechanism sharpens clinical judgment. It means knowing what to watch for, how to counsel patients, and thinking rationally about risks.